But we have with us now from Toronto, I must say, one of the foremost experts in her field in terms of looking at the impact of prolonged healthcare support operations on healthcare personnel. Dr. Rima Styra is an assistant professor in the Department of Psychiatry at the University of Toronto. She is the director of continuing medical education for the University Health Network Department of Psychiatry, and she is part of the broad Toronto healthcare community which coped with and dealt with quite successfully the recent outbreak of SARS. She's done extensive research on the quality of life in patients, on quarantine issues. In addition, she has a study out which looks at the psychological effects on healthcare workers working in high-risk areas of a major Toronto teaching hospital during the SARS outbreak. And so it is a great pleasure that we now invite Dr. Styra to participate. Dr. Styra, welcome.
Thank you. What I'm going to do today is basically talk about some of the issues that we learned from our experience in SARS. My objectives are to actually review the different aspects of the SARS outbreak and how it affected people who were quarantined, people who were healthcare workers, or actually people who became infected with SARS. And I'm going to focus on the psychological implications of such a traumatic event on those affected directly or indirectly. And these would be the patients, again, the healthcare workers, and the community at large. We in Toronto ended up having 251 cases of SARS. We were the fourth largest center during the outbreak in terms of the number of cases that we had, and we actually had 44 deaths. What I want to do is actually clarify for you the whole issue of isolation versus quarantine. What I want to tell you is that it's really important to understand that isolation is really, we're talking about the patient who's ill, the patient who's been infected with the disease, and usually they're in hospital. And it's usually only the individual who's basically isolated. And yet when we talk about quarantine, we're talking about people who are well, who've actually had an exposure to the disease. But usually the quarantine takes place at home, or in some of the Toronto hospitals, we have people who actually were healthcare workers who were going to work during the day because of the manpower issues, and then were in quarantine when they went home at night. And this tends to involve usually individuals, family members, or groups, as in this case, hospital workers in specific hospitals that had SARS patients and exposures to them that were not protected. What I'm going to talk about, first of all, are actually the patients who were diagnosed with SARS. What you need to understand is that when these individuals were placed in isolation, they had no visitors. They were in a room by themselves. They had healthcare workers who came in and wore protective equipment, so they were wearing gloves, gowns, masks, goggles. The time that the staff spent in the room was actually limited, and that was for the protection of the staff. So people saw staff very infrequently, and there was a variability of resources that were provided to the patients. For example, there were many patients who ended up not having a television set or many other resources because there was a fear of technicians or other personnel going into the room and hooking up these resources. So what we thought and what we saw clinically was that by far this was a very traumatic type of event for these individuals. So we started thinking about PTSD, and what we know about PTSD is that it occurs with specific types of illnesses. And we've had rates that have been reported for women with HIV, individuals who've suffered cerebral aneurysms or strokes. What's most interesting is actually follow some work that's been done by Dori Reisman out of the CDC that was actually just published in JAMA in April of this year. And what she looked at was anthrax infection and health outcomes at 1 year. And these were the survivors of anthrax in the U.S. Postal Service. What she found that even 1 year later, they continued to have psychological distress, symptoms of depression, anxiety, OCD, and hostility. And probably that relates to anger. They also had significantly reduced health-related quality of life. And at that time, she actually speculated that PTSD might actually be the mediator of this particular distress. We also know from the literature, in looking at an outbreak of Legionnaire's disease in the Netherlands, that a number of people, 15%, continue to have post-traumatic stress disorder symptoms 17 months after the diagnosis. So what we decided to do in terms of the groups that we looked at was look at the psychological impact, and we were going to use two scales. One was the impact of event scale, which was going to determine PTSD symptomatology, and the other was the Center for Epidemiological Studies Depression Scale, the CESD scale, which has been widely used. Before we go on, I actually just want to let you know a little bit about DSM-4 criteria for post-traumatic stress disorder. It has to be exposure to a traumatic event, and you have to respond to it because you fear that something's going to happen to harm you, that you are actually at risk of death or serious injury. And for the people who were facing SARS in Toronto, this was a life-threatening event. For the people who actually were patients who became diagnosed with SARS, they only not had the situation of having a new emerging pathogen that nobody knew how to treat, didn't know what medication to use, but they also faced the prospect that their families had been identified now as having been exposed to this pathogen. And when these people thought about their family members, be it husband, wife, children, elderly parents that might end up getting SARS, this was extremely traumatic for them. What we know is that there are a number of symptoms that develop with PTSD, and PTSD develops about 30 days after the traumatic event. They have persistent re-experiencing, so they remember the event. They might have dreams about it. They feel like the event's occurring again. And probably the best example is probably the flashbacks that people had suffered who had been in the Vietnam War. The other one is avoidance and numbing. People avoid anything that reminds them of the actual situation where they became infected or became ill. So you can understand that for healthcare workers, who were the majority of people who ended up getting SARS in Toronto, the hospital would actually be a triggering factor. And added to this, they were actually treated within the same hospital systems where they usually got SARS. The third symptom cluster involves outbursts of anger, difficulty sleeping, difficulty concentrating, and hypervigilance. So they're always monitoring their environment. They're always looking around. They're always concerned what might actually happen to them next. And what it also has to cause, it has to cause some impairment, either in their social function, occupational function, or other important aspects that they're involved in. So what we set out to do, and this is actually, what I'm giving you is an overview of a few of the things that we've done, and probably the most recent material that we have is still not yet available. What we did was, in terms of our patients, we took patients who were followed up in a clinic of 2 teaching hospitals, and we recruited them about 4 to 8 weeks post-diagnosis. We had 33 patients, 11 of whom were non-healthcare workers, 22 of whom were healthcare workers. These patients were admitted in March, April, and May, but the majority of patients, about 95%, were actually admitted in March and April, very early on in the outbreak. And they were assessed within 1 month, basically, so between 4 to 8 weeks of diagnosis. And what we found when you look at these pie charts, when we look at the values of PTSD symptomatology, and we're not saying that we're diagnosing PTSD here, we're just talking about symptoms that they exhibited within specific categories, symptoms of PTSD, symptoms of depression. What we see is that the percentages are fairly high in this patient population. We're talking about 58% PTSD symptomatology, 61% depressive symptomatology, and when you look at those who have both symptoms, we're talking about 48%. And the reason why it's important for us to consider both symptomatologies is that we know from the literature that the prognosis is a lot worse when people exhibit both symptoms. We also looked at their quality of life, and this is the medical outcome study, SF36 scores. And what you can see in looking at the various domains from physical function to mental health is that they are all below the norm of 50. So all domains were actually affected by having had this diagnosis and by the fact that this continued on after hospitalization was really the concerning factor for us. So just to sort of sum up a little bit about our patients, we know that we need to follow, and we are following a larger group of patients, which is going to provide us with further data in this area. And we know that the distress that they experience is longer term. This is not like an influenza, which is cured and people go on and leave hospital and return back to their lives. There are long-lasting effects in terms of functioning and psychological effects. The other thing that we looked at was our SARS outbreak was quarantine. And what we know from Health Canada is that about 15,000 people who were exposed to SARS ended up in voluntary quarantine in Toronto. Many of these people were actually healthcare workers. Some were individuals who were the general public, who actually in many ways didn't know what their exposure had been to SARS, but they had either been visiting or undergoing treatment in specific health care facilities that had identified unprotected contact with SARS patients. And some of these people were relatives of people who were ill. And I think for us, this picture kind of sums it up. Basically, it was an illness that people had to deal with very much on their own. They were alone in trying to handle many of the manifestations. And for us in Toronto, it was a very much a mystery illness when we started off trying to tackle this disorder. What we actually did in terms of looking at quarantine because of issues of confidentiality, we actually did a survey. We put the survey up on the net. We announced it through media and via posters in healthcare institutions, libraries, various other places. And we had 152 multiple choice questions. We wanted to look at the knowledge of these individuals and the understanding that they had of the reason why they were in quarantine. We wanted to see whether they adhered to infection control directives and how they had gotten this information. And we also had a large number of open-ended questions. We're not going to be able to cover all of the topics, but we'll cover a few aspects of it. The people who responded were 129 individuals. 90% of them had been quarantined once. 10% ended up being quarantined twice. The median quarantine period was 10 days, which was actually the recommended time period for people to be in quarantine if they'd had exposure to SARS. And greater than 50% of our respondents were healthcare workers. Where did they get their information? Well, because most of them were actually healthcare workers, they actually got their information from their workplace. And the second highest resource was the media. And the media included by far television as the main source, newspapers as second sources. We found that in actual fact, very few found out from public health, only 9%, and from their own physician or healthcare provider, 7%. When we looked at the demographics of these individuals, we found that 64% were within a 26 to 45 year age range. 58% were married, and what was really interesting for us was that 72% had a college degree or higher, so a highly educated, fairly young population group that had ended up in quarantine. What was interesting for us was the fact that even though this was a highly educated group, many of them were also healthcare workers. 15% of those individuals did not believe there was a need for them to go into quarantine. And if you're looking at planning longer term, I think this is a really important variable to consider, that 15% is actually a large number of individuals who did not feel that they should be in quarantine, although they stated at this particular time that they did adhere to the quarantine directives. When we looked at the psychological impact of quarantine, as you can see again, we had a fair amount of distress. 29% talked about symptoms of post-traumatic stress. and 31% talked about symptoms of depression. What we were able to find from our study was that the increased distress actually occurred in lower socioeconomic status groups. We also looked at how people responded to individuals that had been in quarantine, because one of the major things that we had thought about was the fact that we had heard a lot about stigmatization, and a lot of people had actually talked about being stigmatized because they were healthcare workers. And when you look at this particular graph, you can see that about half the people said that people reacted differently to them after they had been in quarantine. Some of the things that they talked about was the fact that people didn't call them, people weren't inviting them to events, and they weren't inviting family members. By far, the majority felt that others were actually avoiding them. The thing that was most distressing for most people was the fact that not only were they stigmatizing the individual who had been in quarantine, but this also extended to their family members. And when we actually looked at adherence to infection control measures, what we found is that we actually didn't do as well as we had originally thought. When we looked at people having to wear a mask in the presence of other household members, only about 82 to 83% of individuals had actually complied. Talking about remaining inside the residence for the period of the duration of the quarantine, less than 60% actually complied in those directions. Temperature monitoring was a really important aspect of trying to determine symptoms and when people should actually go to hospital, because one of the most important aspects of SARS was an elevated temperature. And when we looked at people monitoring their temperature, we were surprised to actually find that about 25% were monitoring their temperature less frequently than was recommended. So that's about 1 in 4 individuals in quarantine were actually not monitoring their temperature for symptomatology. And we found about 7% of these individuals admitted to the fact that they did not monitor their temperature at all. What was interesting for us was that the amount of distress in some individuals meant that they complied with the measures more. With some of the individuals, it meant that they actually complied with the measures less. So we know that distress is present in people who are quarantined. We also know that it has a potential effect in adherence in either a negative or a positive direction. We then are going to go on to our third and last group that we looked at, which was our healthcare workers who actually worked within the hospital systems taking care of patients with SARS, or actually just working in the healthcare facility where there were patients who were diagnosed with SARS. We had about 40% of individuals in Toronto who were healthcare workers who were actually affected with SARS. So for the people working within the hospital system, they were very much aware that their colleagues had been affected by this particular illness. 2/3 of these patients, this is from a study done by Nickel that was published in the CMAJ, reported that they had SARS-related concerns of their own or their family's health. So they were worried what was going to happen. And when they used the general health questionnaire, they found that about 29% scored in an area where you would consider psychological distress. But when they looked at nursing staff, that was greater than 45%. So a higher rate in our nursing staff. And this might have to do with various aspects of the job that they were having to do, which might have had aspects of control related to it. The other factors that we know were affecting the increased level of concern were the perception of greater risk of death from SARS. The more you thought that you were at risk, the higher your level of concern, which makes sense. If you have children in your home, you were much more concerned. If there was something that had happened in terms of affecting your personal family lifestyle, and whether you felt you were being treated differently by people because of working in the hospital environment. What we know basically about emotional distress that was found from Nickel's study was that being a nurse, higher levels of distress. If you were in part-time employment, higher levels of distress, and some of that was actually tied into benefits. The other aspect was lifestyle, again, affected by SARS, and the ability to do one's job. So nursing staff talked about the fact that when they tried to do their work in taking care of patients, and everyone within the hospital system had to do this, which was glove, gown, and wear goggles, it was more difficult because every time you went from room to room, you were having to put on the personal protective equipment. This actually interfered in terms of the amount of time that you could spend with patients and the flexibility of you being able to get in and out of rooms quickly. So we actually decided to look at prevalence and risk of PTSD symptomatology in healthcare workers in a major teaching hospital here in Toronto who were taking care of SARS. We used a survey instrument, which was a 91-item self-administered questionnaire. We had 7 domains that presented possible risk factors for psychological distress, and we used the impact of event scale revised to actually look at PTSD symptomatology. The areas that we looked at were the perception of their risk to themselves, the perception of their risk to others. Did they have confidence in our infection control measures? You have to understand that here, when we started out treating SARS, we actually did not believe that goggles were necessary. After we had a spill in our emergency departments, we then instituted different policies for infection control measures. Whether they had confidence in the information that they were receiving. What was the impact on their personal life? When we talk about impact here, people were actually talking about the fact that when they were returning home from the healthcare facilities, they could not interact with their kids. They felt fatigued, they felt overwhelmed, they felt anxious, they felt worried. What was impact on their work life? Again, the issue that I talked about, the gowns, the gloving. And then how depressing was this whole aspect and the depressive affect that resulted from it. When we looked at PTSD symptomatology, and again we're talking about symptomatology, not diagnosis per se, 43% had some symptoms of PTSD. The factors that we were able to associate with these PTSD symptomatologies were perception of their risk, risk to others, confidence in information. And what we found was not significant was actually confidence in the infection control measures. So they actually had a fair amount of confidence in that particular aspect, and it did not in any way relate to distress. Again, impact on personal life, work life, and depressive affect were important. What was really interesting and of major significance is the fact that when you looked at the avoidance subscale, and so what we're talking about here is healthcare workers avoiding things that might trigger some memory of the things that they're really concerned about, which is getting infected, which is the health of their patients, the health of their family members. And avoidance means that you try to avoid those particular places. And during a crisis, we all need our healthcare workers to be at their jobs. What we found was that the impact on personal life and the impact on work life were actually factors that affected the avoidance variables as well as the depressive affect. So what we feel is it's very important for us to realize that distress does occur amongst these individuals. We need to actually attempt to address these concerns by education and communication. And we need to realize that there would be implications of not addressing these concerns, especially if there were an event where individuals were terrified in terms of the effects that it would have if they were within the healthcare environment and at that point developed symptomatology, that they could handle this distress by actually avoiding the place of concern. So in conclusion, I've given you a little bit of an overview of some of the aspects that we found in these 3 various groups. It's actually just a bit of information. It's a smattering of all of the variables that we've looked at, and there's lots more data that we have around these issues that we hope we will be publishing and presenting in the future. So what we've been able to do is actually quantify the distress as was determined by PTSD symptoms. And we did that because it was based on our own clinical experiences in dealing with patients, healthcare workers, and individuals who were in quarantine, that we found that this was the area that seemed to be most effective. We found that there was real variability in the levels of distress, and this was often related to how people perceived the threat, and that had to do more with personal characteristics. We also know that managing the psychological distress will probably be the determining factor in successfully managing a biological threat. People who are distressed are not as effective, and these people might not be as able to cooperate with some of the directives or some of the things that need to be done. And we know that the system can only be as effective as each individual who makes up the system. Even though people might focus on the good for society, we need to address and make sure that our individuals who are involved in the crisis, who are having to respond to the crisis, are being able to manage their own distress and therefore help with the situation. Thank you. Are there any questions? I can't hear you. I'm actually going to go and get the person to come. Okay.
Just so we understand, if we talk about interoperability, we talk about multi-agency response, we have this model at the back end where, the people you're dealing with, the patients, those who have been infected, are probably going to have some degree of compliance, et cetera. And I think it's very important what Dr. Styra is bringing into the mix here is this understanding that the healthcare workers, that critical group that has to be everyone.
Okay, I can hear you now. I wasn't able to hear you before.
Yes. Dr. Styra, we do have several questions for you. Can you hear us okay now?
Yes, I can.
Go ahead, George.
What can you do to help people recover from post-traumatic stress?
Okay. Post-traumatic stress is actually, there's two different types of treatment basically that are involved in post-traumatic stress disorder. One of them is pharmacological. So we tend to use medications such as antidepressants. And there are two that are actually commonly used, and these are Paxil and Zoloft. The other aspect is we use cognitive behavioral therapy. And why we use cognitive behavioral therapy is we try to refocus the stress that they might experience related to the particular precipitants. So we might use it basically in desensitizing individuals in terms of going back within the hospital care system. So if someone had been working in the emergency department, we would gradually start bringing them back towards the hospital system, getting to the doors of the hospital, going into the emergency department. Those are the things that we can actually do for PTSD. There is a fairly good success rate with individuals, but about 15 to 25% of people continue to have PTSD for years.
Dr. Styra, what strikes me is the fact that as horrific as the SARS experience was for the city of Toronto, at the same time, what we see in terms of, again, hypotheticals, are incidents perhaps on a much grander scale, which would have a ripple effect down through the healthcare community. I don't want you to engage necessarily in fictional projections here, but given the fact that you've done this research on, a fairly limited pool, what do you think needs to be done in order to make sure that this much larger type of, collapse of the healthcare support infrastructure, that is the healthcare workers themselves, what needs to be done to prevent that from happening, given the fact that we might see an incident that stretches out not over a period of weeks, but, 2-3 months or more.
Mm-hmm. Well, in actual fact, our SARS continued on for a fairly lengthy time period. It started in March, it continued on to April. We had a second outbreak in May, and things really came back to normal probably by the end of June. So our healthcare workers actually had to deal with this for a fairly lengthy time period. I think what we found is that people actually rise up to the task. We know that we label many of our healthcare workers heroes. And many of them basically said, I stepped forward and I did what I really needed to do. I think that addressing the fact that these people actually went out on a limb and did what we expect them as society to do, but we also need to recognize that they need some assistance in doing this kind of work. I think that they need to realize that there is recognition for having done this work. And one of the things that has been a major factor is the fact that there was a lot of initial response to the healthcare workers' concerns. It dissipated very quickly when the system started to feel like it was being overwhelmed. So healthcare workers want to know that when they need the resources, when we needed N95 masks, they want the healthcare system there to provide that for them. What they also wanted was for further education in terms of the general public, and the general public to understand that these people were not basically going to be the carriers of this disease into the community. So they found it very difficult that when they tried to access services themselves, such as dental services, when the dentist found out that they were actually a healthcare worker, the dentist said, listen, we'll see you in 3 to 4 months from now when all of this has passed. When they went to dry cleaning, people had their dry cleaning refused because they knew they were a nurse or a physician working in a healthcare facility. So I think there's a lot of work that needs to be done in educating the public and providing resources for healthcare workers to feel like they will be safe and comfortable in the environment that they're working in.
But in terms of educating the public, as you pointed out a moment ago, you indicated that most of the people surveyed said 9% got information from the public health sector, and that the vast majority relied on, information they picked up in their workplace or TV, that is the media. And do you see a greater need to emphasize a proactive public health role in communications, including, going so far as to seizing, some access airwave to the general public in the event of some larger scale event, as opposed to leaving it up to the media to filter the information? Or what would you...
Yes, I think people really wanted credible sources of information. And what we actually had was we had a number of individuals who on a daily basis provided information. And we knew in Toronto that at 3 o'clock on a daily basis we would have a public health briefing. And everyone tuned into the public health briefing. By far what we found was television is the most powerful source of information. We thought people were going to be turning to the new technologies, that they would be surfing the web, that they would be looking on the internet. That was actually not the case. What they were actually doing is they wanted to see somebody who was actually speaking to them in a medium that was easily accessible, and that was the television. And I think the concept of having a public health channel that would provide information on an ongoing 24-hour basis for individuals during a crisis like this would be absolutely wonderful. Because I think what we also found was that media sometimes tends to sensationalize some of the aspects of these outbreaks.
Well, Dr. Styra, I want to thank you. I must say that you're addressing, non-psychiatrists and non-mental health care worker types out here in this audience. I wish we could perhaps tap into your more clinical expertise, but again, we appreciate you being here this morning very much. Thank you.
Thank you very much for having given me the opportunity to speak with you. Thank you.